Good evening, friends. I'm Dr. Kaladhar, Head of the Department of Critical Care at Yashoda Hospitals, Malakpet. Welcome to our Tuesday Masterclass webinars from the Department of Critical Care Medicine from Yashoda Hospitals. We bring forth these sessions regularly, time to time, like almost more than 5 years. So every alternate day, we have masterclass where two students will be presenting an interesting case from their unit, which is going to be that happens in the exams across different platforms like DRNB, DM, IDCCM. These students they go and these recorded sessions are there on YouTube. So as masterclass Yashoda, so they revisit regularly. The feedback what we got is they could learn a lot from, especially exam point of view from these sessions. So we are happy with that. So without much delay, today's topic for discussion is snake bite envenomation. So this is a very important time critical emergency, I can say, from intensive care point of view. The patients can present with varied presentations, where most of the times I think we will be discussing about the criticality, and our case was a bit interesting, and especially regarding how to diagnose, what are the different presentation they come with, how much to give ASV, what is the bedside assessment. These things are very, very important, and I can say this should be mastered, especially the critical care students and even across the consultants, still we can learn. So I think to have like for this expert-led examiner, we have two good expert and seasoned examiners with us. I would like to introduce Dr. Dhruva Chaudhary, sir. Sir is, I think, very well-known, renowned, I think, his teaching methodology, making everything, whatever complex matter into simple fund. I would always like to listen to his sessions very regularly, and across different platforms are always as there as an academician. He's the head of the department at PGI from Rohtak. So everybody knows that. So welcome you on board, sir. Yes, sir.
Thank you.
So I welcome another examiner, Dr. Shashwati Sinha, ma'am. Ma'am is a senior consultant there at Manipal Hospitals, Dakuria from Kolkata. I think madam is very well known, and she is always pro for academics and involves across different platforms, had given immense or whatever the experience to ISCCM across different platforms. And we are very honored to have you also, ma'am, on our platform. Welcome. I welcome you, ma'am.
Thank you, Dr. Kaladhar. It's a pleasure to be a part of this platform and to attend the session with Dhruv Chaudhary, sir. I think it'll be a good learning experience for me as well. Thank you.
Thank you. Thank you, ma'am. So to discuss this topic, we have with us our two students from Yashoda Malakpet. So Dr. Vikas is the second year DRNB student, and Dr. Ravikant is IDCCM students. They both will be presenting our interesting case that we dealt with in our ICU. So Dr. Vikas and Dr. Ravikant, you can proceed with your case discussion.
Thank you, sir. Good evening, sir. Good evening, ma'am, and good evening, everyone. A 48-year-old male, resident of Suryapet, farmer by occupation, presented with chief complaints of severe epigastric and retrosternal chest pain with sudden onset breathlessness and decreased responsiveness since today early morning. Coming to history of present illness, patient was apparently normal till last night. He woke up around 4 a.m. in the morning, following which he went to farm for harvesting vegetables. Later went to vegetable market at around 6 a.m., where he started developing severe epigastric and retrosternal chest pain with increasing intensity associated with nausea and severe headache. Initially, he was evaluated in an outside hospital for the above-mentioned complaints and was intubated in view of decreased responsiveness and impending respiratory failure. Initial evaluation showed ECG is suggestive of premature atrial complexes with sinus bradycardia and non-specific ST changes, for which he was given loading doses of tab ecosprin 300 mg, tab clopidogrel 300 mg, tab atorvastatin 80 mg, and injection heparin 5000 international units, and was shifted here for further evaluation and management. Coming to past histories. He has no history of any diabetes mellitus, hypertension, and he has no history of any similar complaints in the past.
Can you come back to the history again, my dear?
Yes, sir.
Go back. Now, you see, go back. Look at the history. You have shortness of breath, decreased responsiveness since morning. Now you come forward to the next. This is the three features: abdominal pain, chest pain, shortness of breath early morning, slept well, and decreased responsiveness since morning. अब आगे आइए, ठीक है ना?
Yes.
अब ये जब उठ के गया ठीक ठाक है. When he went, it was fine. Epigastritis in onset severe intensive nausea and severe headache. Now, what will be the differential diagnosis for these things?
So the possible differentials could be some cardiovascular side, acute coronary syndrome,
One,
and
what else?
aortic dissection.
Aortic dissection will be usually in the interscapular areas in the back rather than the front area, but can have a severe pain.
And can be massive pulmonary embolism.
That is one part. What else?
And we should also rule out from respiratory side, like it could be any tension pneumothorax.
Whatever you are talking in terms, which is very important to remember is a headache. Why should a person will have a headache with it? If a person who is otherwise fine, doing well, coming it up. So what you are saying is true. So you can also have to think in terms of any hypertensive urgencies or emergencies which
Yes,
can
sir.
happen,
Can
even
be,
if it is not
it can
there.
also be a brainstem stroke.
Okay. चलिए आगे. Now, where he's suddenly becoming unconscious. Have you ever heard of any acute coronary people becoming unconscious so suddenly? That means there has to be issues. If you are finding it a grade 3, grade 4 MMRC, all right. But what happened to this patient? Responsiveness, was any crepitations? Nobody has mentioned. If somebody has a coronary and a breathlessness, no doubt will have a pulmonary edema.
Yes, sir. Yes.
ठीक है ना? So that will be pulmonary edema. Where is the pulmonary edema? Lungs are dry. What's not like? You have just intubated it. ECG suggestions of premature atrial complexes with bradycardia. That's what you are looking at it. Why usually with you PSCs? Now let's come down to, obviously somebody thought in terms of acute MI, did it. Come to the next slide. Now you look at it. This patient has a bradycardia. Have you finding anywhere any evidence to suggest coronary?
No, sir. No, sir.
Now, what is the corrector of this bradycardia? Is it a sinus bradycardia, or it is a complete heart block, or whether you are having any issues of this bradycardia related with the ventricular ectopic?
It is not looking like a sinus bradycardia, sir. Like there are PVCs, atrial and ventricular premature complexes with and mostly looking like a junctional rhythm rather than sinus bradycardia, sir.
Now, if you see it here, is it couplet? Is it two ectopics? How will you interpret and read this? Can you read this ECG for me?
So here the ECG, it is so the ECG, sir, it is actually it is well calibrated, and now the ECG is showing the patient having a sinus bradycardia with having a bradycardia with heart rate of around 59 beats per minute, and there are the RR interval here is seems to be regular, but in between there are premature and ventricular and atrial complexes which are intervening the conduction that is happening, sir. So it is looking like more of like the PR interval also seems fine. So more, but there are multiple atrial and premature ventricular complexes which are intervening. Looking more than a heart block, it is looking like a sinus bradycardia with APCs and VPCs, sir.
Shashwati, any of you have questions on this?
What bradycardia? You initially said that sinus bradycardia. Can you see P waves in every complex?
No, ma'am. Not in
No.
every complex you can't see the P waves, ma'am.
Right. So I think we should stick to bradycardia itself per se
Yes,
with
ma'am. Yes, ma'am.
complexes, because in that case, and then you cannot talk about PR interval, right?
Yes, ma'am.
You can't see P waves, then how can you speak about PR intervals?
Yes.
So would you like to modify your reading of the ECG?
Bradycardia with multiple atrial and premature ventricular complexes, ma'am.
You see, let's say if I say this patient has an increased ICP and then it is leading on to it, because we need to put it up, what is the cause for the sinus bradycardia? If it is an acute coronary event, your lung is dry, you have not mentioned anywhere. Tube point has put it, no, nothing is there. So along with this bradycardia, patient had a severe headache also. Can this happen if somebody has an increased intracranial pressures?
Yes, sir. Secondary to the Cushing's reflex, there can be secondary to the
That
right
is what I'm
ventricle.
saying. Whatever you have prepared, your information is not adequate. You need to look at heart rate. You
Yes,
need
sir.
to look at blood pressure. You
Yes, sir.
need to look at respiratory rate. And in
Yes,
the
sir.
examination, again, you have not commented at all, whosoever it is there, prepared it, about whether lung was dry, lung was wet, because a lot of these things change with it. And secondly, obviously, we need to see these things. Obviously, these are the normal things which are there, and there we are finding ectopic activity. So how you differentiate between ventricular ectopic and atrial ectopic?
Ventricular ectopics, they have a wide QRS complex, sir. Whereas the atrial ectopics usually they have the broad QRS complex is generally seen in ventricular ectopics rather than atrial ectopics. Since the conduction pathway is normal since in atrial ectopics, since the focus of origin is not the SA node and it is from the other atrial myocardium. Since the ventricular conduction system remains normal, in case of an atrial ectopics, the QRS complex remains narrow, sir. Whereas in case of ventricular ectopics, since the origin is from the ventricular myocardium, usually the complexes are
So
wide
you
QRS
look at
complex.
the origin also, that is fair
Yes.
enough.
Yes,
What
sir.
about the compensatory phases, which are there in which one more, in the ventricular or the atrial? Please go and read ECG. It is very important. They look very basics and fundamentals. Am I right, Shashwati?
Yes, sir, absolutely. I think if you present an ECG like this, not only in the case per se, even when you're going to go for the multiple tables, and if you're given an ECG like this is the basic thing which you need to know, right? About the compensatory phase in an atrial and ventricular premature complexes. Yeah. So this is not very advanced. Please go back and have a look and just figure out what we mean by this. Okay.
It is very, very important. Because if you read the AI, given they are talking premature atrial contraction, you are talking to me about ventricular contraction. That's why I put that question. And you see how you differentiate between the. If we are not aware about the differentiation, then it becomes a problem. So probability, let us say there is a sinus bradycardia, no doubt about it. And along with it, we are having in these cases, which one do you think is the conduction blocks, and where do you think we are seeing the ectopic activity? Is it this is ectopic or this is ectopic? Because this is wrongly interpreting, but I go by you that these are ventricular ectopic. Let's go ahead with it quickly.
On arrival to ER, patient was brought in intubated state with GCS of E1, VT, and M1 with bilateral pupils 3 mm not reacting to light. The last dose of sedation and paralysis at the outside hospital and during the transit has been not documented. Airway was secured with cuffed endotracheal tube in situ. Coming to breathing, saturations were 99 on mechanical ventilator support with FiO2 of 60%, PEEP of 5 cm H2O, and tidal volume of 450 ml and RR of 19 cycles per minute. His blood pressures were around 190 by 90 mmHg with heart rate of around 124 beats per minute. On arrival, an ABG was taken which was showing pH of 7.319, PCO2 of 41.6, PO2 of 150 and bicarb of 20.6 with elevated lactates of 4.6 millimole per liter with anionic gap of 18, and P/F ratio is 250, and delta ratio of 1.5, suggestive
May
of
come back. Now, this patient has tachycardia, this patient has hypertension, and obviously you are intubating and doing it. Why there is a discordance here? Or do you think this is a sympathetic excess which is taking? And then how will you explain that ECG with this, with the heart rate?
That
So that ECG was
in
at the
the
outside hospital, sir.
Okay. Now, what is your blood gases? Can you read it for me?
pH of 7.319, PCO2 of 41.6, PO2 of 150, bicarb of 20.6, lactate of 4.6 millimole per liter, anionic cap of 18, and P/F ratio of
And then
250.
what is the interpretation?
So this it is a case of here we have calculated the anion gap, which is around 18, sir, which is
That is all right.
yes, sir. So it is and the delta ratio is around 1.5, sir. So it is a case of anion gap metabolic acidosis with lactic acidosis, sir.
What about CO2 for this?
Yes, sir.
Is it normal?
The expected PCO2 at this point of time is around 36 to 40, sir. So it is slightly on the higher side, sir.
Doctor, am I associated respiratory acidosis?
Yes, sir. Yes, sir.
Concurrent respiratory
Acidosis also.
Great. And is your PO to FI2 ratio normal?
It is not normal, sir. It is
Here.
less than 300, sir.
So hypoxia ho gaya. What
Yes,
is the
yes.
cause of this hypoxia?
At that point of time when the patient was unresponsive at the other hospital, there could be a possibility that the patient's airway was not protected and could have resulted in aspiration. And
Why aspiration? How will you calculate aspirations? The reasons and the ground for science. Have you calculated alveolar arterial gradient? This patient has got combined acidosis.
yes, sir.
Dominantly as metabolic. You had this patient hyperventilation. CO2 continues to grow in spite of your rate of 19, and you're keeping a tidal volume of 450. That means minute ventilation is roughly how much? Roughly
450 into 90.
4.5 है ना into
9
19
liters.
20 कर
9
लो आप.
liters, sir.
9 liters.
9 liters में भी आपका इतना आ रहा. Or you may have done it earlier on arrival, probably when patient may not be having on this. But if you have to really look at it, you need to see VQ mismatch है कि नहीं. अगर VQ mismatch है, then you will talk in terms of कि there is an aspiration. If there is no VQ mismatch and it's all normal, then it will go with the hypoventilation.
Yes, sir.
Am I right or no?
Yes,
Yes.
sir. Yes, sir.
So when you are doing it, write full interpretations, and then you find whatever you speak, it needs to be done. What is the other way of looking at it? Okay, that alveolar ventilation is inadequate. How can you make it out besides PCO2? Do you know VDVT क्या होता है? Do you know the VDVT ratios? How you calculate? Any idea? But your alveolar ventilation can be low only then CO2 will go up. So if your dead space increases for some reasons, then again you will see it. That is why we always calculate alveolar gap and VDVT. Saraswati, do you agree?
Absolutely. And I
Because-
think at least A gradient should definitely, especially in this patient, when you said that he could have aspirated. So how would you know that whether the hypoxia is because of hypoventilation or there is some pathology which is causing a VQ mismatch? So whenever you have hypoxia, whenever it's not only or an ABG interpretation, don't always just talk about acid base. Definitely talk about oxygenation, ventilation, and acid base, right?
Yes, ma'am.
Not only PF ratio, but also what explains the PF ratio.
Okay.
Okay.
See, you're already coming with we are presenting a case of Snake Bite. But the question is how the physiology is evolving. We need to understand that. Because that tells us about what complications are happening or what are the consequences which are part and parcel of the primary side. Is it clear?
Yes, sir.
Yes, sir.
Chaliye aage.
CT brain was done in view of low GCS, which turned out to be normal. And a ECG was also taken here, which was suggestive of non-specific STT changes. And TROPE was done, which was 0.43, suggestive positive. And 2D echo was done, suggestive of severe LV dysfunction with regional wall motion abnormality with an EF of less than 30%. In view of above echo findings, cardiology opinion was taken and patient was started on dual antiplatelets, tab ecosprin 75 mg 24th hourly and tab ticagrelor 90 mg 24th hourly along with anticoagulation injection clexane 60 mg subcutaneous 12th hourly and was planned for coronary angiogram after stabilization of the patient. And apart from the above investigations, we have done routine blood investigations, which included complete blood picture with peripheral blood smear, RF renal function tests, liver function tests, and coagulation profile, which include PTNR and APTT. And he was shifted to ICU for the further management.
You tell me one thing, what did you gain by doing SCT in it? What was the rationale? Did you find any focal neurological deficit? Because if you have a stroke, focal neurological deficit. Now, it's not that we have to do as a part of protocol, that's all right. But if you look at the evaluation of an unconscious patient, CT, was there any signs to make upper motor neuron signs थे कहीं पे? आपने कहीं नहीं लिख रखा examination पे कि this patient has a lower motor neuron sign, whether this patient has an upper motor neuron sign. What were the clinical evaluation about the cranial nerves? We are jumping straight away. This is a very common practice which people are doing. Did anybody examine the cranial nerves?
Sir, actually, patient couldn't.
At the point of presentation, when the patient was arrived, brought to the ER, sir, the patient was
GCS was around E1, VT, and M1, sir.
and his
That is all right. That is fine.
and the last dose of neuroparalytic agent as well as sedation hasn't been documented. We try to elicit the signs and symptoms. We try to elicit the clinical evaluation of including the neurological findings, but the patient wasn't showing any neurological signs at the point of time in the ER.
See, this patient, when you looked at it,
Yes, sir.
if this patient at any point of time was having any external ophthalmoplegia, internal, you still can see it because
Yes, sir.
autonomous chalta. That is what we look at it.
Yes, sir.
And then at the same point of time, anything to suggest ptosis, or we found any drooling or retention of secretions, which was there in the mouth, saliva was rolling down, was anything to suggest seventh nerve palsy, you don't need anything else, it can return. Similarly, what about the deep tendon reflexes, any tenderness anywhere? All these things we need to look at, my dear. Any neck signs? Was there curling? And did you look at neck? Was when you took this patient, was he having any broken neck side? Point I'm not saying. It's possible that they may have given him, let's say, neuromuscular blockers, sedation, accepted. One very common thing is when you ask these patients to tighten their, you can see the furrows on the head, which we commonly tend to see it. Or if they find it difficulty, then you ask them to blink their eyelids, they do that. So all these things we need to know about it. No? Simply saying it, unless and until I'm very certain that neuromuscular blocker में sedation में तो नहीं होगा. What was the pupillary size? Nowhere did you mention about it. Was there anisocoria? Was there any afferent reflex there or not? We straight away jumping on to CT. CT with an idea that whether this patient has got an IC bleed or not. That is the only idea of stroke. So, but if there is a stroke, then you have to be focal neurological deficit. Shashwati, what's your take?
Even if they are sedated and paralyzed, at least, when you're doing presenting, apart from the history, you should have had a detailed neurological examination. And when you come to motor or cranial nerves or whatever it is, at least whether there was any movement of the eyeballs anywhere, like Sir mentioned, ophthalmoplegia, whether there was a gaze preference onto one side, all of those things, pupillary size, whether there was anisocoria, that is usually not impacted by, sedation and muscle relaxants to that extent. So at least mention, there has to be a systematic mentioning of the clinical examination, general physical examination and your systemic examination, just mention. And if you cannot elicit any particular thing, say you cannot elicit neck rigidity, just let us know, isn't it, that you did look for it, but this is the reason why you could not do it. That's what Sir is trying to tell you, because this has to be a habit, Nowadays we are so into investigations that most of us try to skip this, whatever is essential. But for an examination and definitely later on, this is something which you cannot skip. So henceforth, whenever you are presenting a case, please make sure that you go through the whole template of examination.
Okay.
Why I'm asking these things is not to let you down. Basic idea is that this is not everywhere. This is a very common mistake. And you tell anybody, they say you are old timers. But trust me, these things save money. It makes consolidate your diagnostic skills, and you are able to make it up. Still, if you want to plan it out, rule it out. If one indication for me will be there, if you would have told me next signs present, I would have tried to rule out straight away subarachnoid hemorrhage because increased BP, is तरह की changes, ECGs, you may have it. But for saying stroke, it has to be focal neurological deficit, acute onset. That is what we all talk and discuss all the time, right?
Yes, sir. Yes.
ठीक है, हाँ, चलिए आगे। ना पीछे ECG पढ़ो भागो आओ मत।
So this was the ECG which was taken at our hospital when the patient had arrived, sir. So here also the ECG is calibrated, and it is showing a sinus tachycardia of with heart rate of around 124 beats per minute with regular RR interval, and there is around ST depressions in the leads 2, 3 and AVF, but which are not significant, and otherwise these are the findings, and there is QRS progression also, sir, which is seen adequately from V1 to V6, and there are no other T inversions or any other changes, sir, except from this.
Sinus tachycardia there, but we are
Yes, sir.
finding very large voltages.
Yes, sir.
Sometimes people may come, they may have it, but nevertheless, it's better than what you talked about. Let's move on. It's just sinus tachycardia.
Yes, sir.
चलिए आगे. A non-specific STT, small Q waves here and there, etc. For MI, how many leads should have Q waves or changes in T wave, STT segment and T wave?
More than or equal to 2 contiguous leads.
Two contiguous. So that is not there. So it is unlikely to be
Yes,
acute
sir.
coronary.
Yes, sir.
चलिए आगे. All these things we interpret.
Yes, sir. So these were the investigations when the patient had initially arrived, showing significant findings in the form of raised TLCs with a near normal liver function test and a tropi which was positive of around 0.43, and renal function, the electrolytes as well as the coagulation profile were all appearing within normal limits, and the serum amylase and serum lipase were done at this point of time, keeping the differential of acute pancreatitis in mind, which also turned out to be normal, and HbA1c is around 5.4. So these were the investigations on the arrival, sir. Further course in the hospital, in the ICU, despite withholding, once the patient has been shifted from the ER to the ICU, despite withholding the patient of any sedative and muscle relaxant, the patient's neurological status continued to remain low, with the pupils fixed and dilated and absent brainstem reflexes, where the corneal, the pupillary, the Dolce reflex, and the cough and the cough reflex, and which were all tested, were found to be negative, sir. So since the clinical parameters are not correlating with the patient's clinical condition, we had a strong patient being a farmer, and with the sudden onset of these symptoms with the background sudden decreased responsiveness, and a patient requiring having a respiratory paralysis and requiring intubation, we had a strong clinical suspicion of snake envenomation. And we have done a thorough physical re-examination, sir, at this point of time, which revealed no overt bite marks. And at this point of time, in view of to rule out snake envenomation, we have got a 20-minute whole blood clotting time test done, which was found to be less than 20 minutes. And hence at this point of time, we have ruled out hemotoxic snake envenomation, and with keeping in mind the neurotoxic snake poisoning, which is closely mimicking the underlying presentation of the patient. We have given a loading dose of 10 vials of ASV, following which fasciculations and gentle voluntary flickering movements were noted in the right lower limb, sir. At this point of time, we even subjected the patient to an atropine neostigmine challenge in order to differentiate whether the neurotoxic envenomation is a crate or a cobra. Following the atropine neostigmine challenge, there was no significant improvement in the neuroparalytic symptoms. So we have resumed with the second dose of 10 vials of ASV at the end of 1 hour, and followed by injection calcium gluconate 1 gram 8th hourly. So this was the interventions which were done at our
See, again, you're looking. Can
Yes,
you
sir.
tell me the differential diagnosis of fixed pupils with fixed dilated pupils with absent brainstem reflexes?
Yes, sir. There are multiple mimics of brain death at this point of time which can occur. Patients with who are having drug intoxications and with high cervical spine cord injury or botulism, and patients who for severe snake envenomation secondary to neuroparalytic snake bites, as well as in patients with pontine infarcts where the patients have, but there the pupils are reactive in locked in syndrome.
Now let us come down to where
Yes.
was the need to do a 20-minute WBCT whole blood counting test? If this patient would have been there, it would have been bleeding from the site. One. Secondly,
Yes,
where you see basically in vipers or whether it is a Russell viper or it's a saw scale viper, you don't have any local injury, local mark, no bleeding. So as a part of theoretically, it's okay, but it clearly tells you this is not any of those grades except. Can you name which particular snake you can have both hematological plus neurological symptoms?
yes, sir. It's commonly seen in Russell's viper, sir.
It is in the boya, take Russell's viper.
Yes, sir.
So you don't have any bleeding, you don't have a local sign.
Yes,
So
sir.
that is very unusual. So it's unlikely that this would have added to it. All right.
Yes, sir.
So and obviously, when you look at it, obviously fasciculation, gentle ventricular filtering. What do you mean by this?
That the patient was responding to the ASV, sir. That the toxin, whatever whatever residual toxin was there, and which was not irreversibly bound to the receptors, could have been neutralized by the first dose of ASV, and could have resulted in improvement in the patient having voluntary flickering movements and fasciculations, improvement in the motor symptoms secondary to the ASV, sir.
Why did you give atropine neostigmine challenge?
We had given it actually to differentiate whether since we had a suspicion that it's a neuroparalytic, in order to differentiate whether it is a cobra bite or a crate bite, we had actually given a atropine neostigmine challenge. But the cobra bite usually comes with local severe manifestations, which is not seen in crate bite. That could have been one.
And why calcium gluconate?
So calcium gluconate also because presynaptically it improves the it helps in the release of acetylcholine. So that is the reason we have given calcium gluconate, which works well in presynaptic neurotoxins like crate bite, sir.
Shashwati.
So what would be your expected response to this atropine neostigmine challenge?
Following the atropine neostigmine challenge, if the patient, if it is a postsynaptic neurotoxin, there will be a 50% increase in significant increase or 50% increase in the doses at the end of an atropine neostigmine challenge, ma'am.
Okay. Anything else?
And
Just
even
doses will improve, or any other things will improve?
Even the respiratory paralysis, in case the patient has not, if the patient was having a respiratory distress at the point of time when the patient had witnessed cobra bite, and that at that point of time, if you would have given an atropine neostigmine challenge, there could also be a significant improvement in the respiratory weakness and respiratory distress. So at all levels of the neuromuscular junction where the venom is acting, causing a postsynaptic blockade, at all those levels, the atropine and neostigmine will replace will increase the levels of acetylcholine, thereby causing competitive replacement of the venom receptor complex by acetylcholine, thereby bringing about a improvement in the overall muscle strength of the patient.
Yes, so it will not only be restricted to your ptosis, ophthalmoplegia. If somebody is having neck muscle weakness, so that would improve.
Yes, ma'am.
Your respiratory muscle function will improve. So you will need to see whatever has been, you think has been caused by the envenomation. So you should try to assess all of those responses. Yeah.
Yes, ma'am.
Okay.
So this is the fasciculations which are noted.
Please go ahead.
Yes. So further course in the hospital, ma'am, a neurophysician opinion was obtained at this point of time, and the neurophysician had actually advised for an EEG, EMG, and repetitive nerve stimulation. EEG was suggestive of diffuse cerebral dysfunction, and EMG and repetitive nerve stimulation was suggestive of both presynaptic and postsynaptic neuromuscular junction disorder. Following 20 vials of ASV, patient regained consciousness with a slight improvement in the muscle power, around 2 to 3 by 5 in all four limbs. The following day neurological examination revealed a GCS of around E3 VTM6, and although there existed mild weakness, the patient was able to move all four limbs. Dual antiplatelet therapy was modified to tablet ecosprin 75 mg once daily, and repeat 2D echo has been done at this point of time, which showed a resolution of cardiac dysfunction with good LV contractility. This was the RNS and EMG study which was performed, ma'am. And it was showing a significant decremental response in the right abductor pollicis brevis, the left abductor digiti minimi, and the right trapezius, with
See,
significant.
it is consistent actually with the you
Yes.
expect with the crate postsynaptic, and
Yes,
at
sir.
the same time also some amount of them may have a mixed venom, so presynaptic. Dominantly, if it would have been presynaptic, it would have responsive. So this is expected with minimal or no response to atropine and neostin,
Yes, sir.
right?
Yes,
So
sir.
this is as per the expected. Usually, if we don't do it, I take it like this. You still people were in doubt. That's why you went for it. But nevertheless, nothing wrong in it, and it is consistent with it. Let's move ahead.
Yes. And these were the other investigations through the course of the hospital. And the significant thing was initially the TLCs which are elevated. Once after the initiation of the anti-snake venom, there was a gradual decrease through the course of the hospital stay, and the other lab parameters showed no significantly evident changes. And the final diagnosis at this point of time is the neurotoxic snake envenomation, which is a possible unwitnessed occult grade 3 crate bite, induced cardiac dysfunction, mimicking brain death.
See, if can you make it better? Simply, why don't you say neurotoxic snake envenomation? Probably crate. That's it. Then you are having it because number of these people who have a significant dysautonomia. We don't talk about it, but that is what you see. If I look at your reports which are coming up, if nothing else, if you give two ECGs, one side you are finding a tachycardia, sympathetic activity, other side you are finding a parasympathetic activity. Secondly, number of these patients also have a muscle injury. That's why your TROP-I is high. TROP-I doesn't mean cardiac only, but ECG, echo are suggestive of that. But nevertheless, because usually it should be diffuse myocardial injury, so I will suggest this patient on a follow-up must have a cardiac evaluation. Otherwise, they should not be in terms of coronary artery disease. Otherwise, you will not have original wall motion. One. Secondly, we should say lock-in state. Don't say mimicking.
Yes, sir.
Cardiac dysfunction is not mimicking brain death. It's a neurotoxic snake envenomation, probably crate A with severe cardiac dysfunction and B with respiratory failure. One with B cardiac dysfunction and C is your it is that neuroparalysis which is lock-in state.
Yes, sir.
Most of these patients continues to have a sensorium. EEG has shown diffuse activity because of the decreased brainstem function, or probably maybe people might have used a little more of sedatives in these cases, because that is very fundamental. Body ache pain is very, very important. I've seen people treated for acute pancreatitis, people being treated for appendicitis, people being opened up for these acute abdominal emergencies. So this is all because of muscle injury. The only odd thing I'm finding is your liver enzyme, especially SGOT, is normal. So ideally, you should have done in these patients CPK also when TROP-I was there, and that also is an indication for admission in ICU at more than 5,000. And gradually it resolves and things settle down. So I think you need to revise your diagnosis, otherwise it gives an impression that it was cardiac dysfunction which was causing mimicking of a brain death.
Okay, sir.
Are you getting my point? Similarly, another thing is Takasubo is the another one which you need to see, because sometimes acute stress comes up quite often. It may not be snake envenomation, the anxiety, neurotics, which happens with a marked surge. This can cause it, though it was not there in this case. But that is again a apical ballooning regional wall motion abnormality. That's what I have to say as what you have written.
Yes,
Dr. Shashwati?
Yes, I think, and when you spoke about regional wall motion abnormality, whether it was actually regional wall motion or was it just global dysfunction or was the apical ballooning, that is something, that would be important, and that is something which needs to be kept in mind, because if there was regional wall motion abnormality, it is very unusual that it will come back to normal cardiac function in 2-3 days or so, right?
Yes, ma'am.
Yeah. So what exactly was contributed to the LV dysfunction is something very important. And like Sir mentioned, it is very important that I think your diagnosis needs to be neurotoxic snake envenomation related to crate bite. All of those other things are a part of the whole story, I guess.
Yes, ma'am.
So what about the abdominal pain? Could it be
And
justified by this case? Does it happen?
uh, uh, yes, ma'am. Usually, abdominal pain occurs secondary to the mucosal injury, secondary to the snake toxins. They can cause mucosal injury, and that can lead to abdominal pain in patients in this group of patients, ma'am. So,
No, dear, no. It's a severe muscle injuries, which is called myotoxicities. That is responsible for the pain in this, not the other way around. It's
okay.
not mucosal erosions, etc.
Yeah.
It is myotoxicity, which
Okay,
is
sir.
responsible. That is why I'm saying CPK is important.
Yeah. So CPK that would have given you an indirect measure of the myotoxicity, right?
Yes.
Please go ahead.
Following successful spontaneous breathing trial with improving muscle power in the form of adequate neck holding, facilitated weaning onto NIV was done on day 4, and the patient continued to improve, was weaned off NIV and shifted out of the ICU and discharged in a hemodynamically and neurologically stable condition on day 7, ma'am.
You see, again, I say, please say that we don't do facilitated weaning on NIV because they continue to have a neuromuscular weakness. In this patient, you are simply given 20 units of ASV. He responded. The persistence of weakness is because of inadequate dosing. You need to give nearly, in this sort of a severe, around about 30 units of ASV, because you need to know we are getting a polyvalent. It can be either liquid form or it can be lyophilized. So they will have 0.4, 0.4 and 0.66 for
Yes.
2 watts. So for the crate and for Russell Viper, you will have 0.6, for other 0.4. This is how the neutralization is calculated. And it is irrespective of the age, irrespective of the size, amount given has to be consistently same because you're neutralizing the venom, one, free venom. Secondly, you must use prophylaxis in this. Anaphylaxis is 0.5, 0.3 units of adrenaline must be given to all these cases. Today, we don't do any testing for sensitivity. We simply give them 0.3. This is the national protocol, ICMR, as well as the NCTC. Give them a shot of, if it is a bleeding one, there you need to be careful. Because there, then you give bleeding, you look and you continue to follow these patients with whole blood type or the slide test. All right.
Yes, sir.
And obviously, beyond that, if your patient doesn't respond, either it's a different series, different species like pit vipers, we are seeing it now, or alternatively, your snake venom is not working, so change the prime. These things are very important. We never put these patients on NIV as far as possible because of very simple reason. They have a bulbar paralysis. They may cause aspiration. So facilitated weaning is not at all recommended. Recovery should be there when your necks have come up. When he can hold the neck practically, it means he's having an adequate amount of time. That's why we always look at. That's why broken neck sign is very important.
What are the other criteria? I'm sorry, sir. Sir, please go ahead.
No,
Sorry.
please go ahead. Please go ahead.
And what would be the other criteria apart from adequate neck holding before extubating this patient?
We look at the weaning indices, ma'am, and the weaning indices, we look at the rapid shallow breathing index, and we integrated indices also we have.
See, here we are more concerned not only about the
power.
winning indices.
Yes,
We just
muscle
need
power.
to be sure about the neuromuscular recovery.
Yes,
So
ma'am.
apart from neck holding, which are the other things which you think will be important? Why was Sir mentioning that these patients may not be an ideal people to be facilitated onto NIV?
You have to
What could be the other issues?
rule out the bulbar weakness, and so adequate ability to hold cough and swallowing reflexes, and adequate muscle power in all the peripheral limbs with adequate deep tendon reflexes. These things also should be kept in mind before extubating these patients in order to prevent the post-extubation risk of aspiration.
Absolutely. Amount of secretions, the effectiveness of the cough, the ability to hold the neck. So all of these need to be put together before you extubate these patients, right?
Yes, ma'am.
But the interesting thing is, nowhere you have mentioned about doses, not even once. And along with it, what is happening to the extraocular muscles, which is very fundamental. They improve. Remember one thing: march is from craniocaudal, recovery is from caudal to cranial, and these they recover quickly, and head holding, and then subsequently ability of the person to swallow. Dysphagia is underplayed thing in the critical care. If a person can swallow further along with it, then there should not be any issues.
Yes, okay, sir.
ठीक है ना?
Yes, sir.
चलिए, ठीक.
Sir. So, yes, sir. I think we came to the end of the session, but I think some of the like questions that comes to like our clinicians at the bedside in especially the ICU. So what do you think, as you were telling about the ASV doses, sometimes we can go up to 30 vials and all. So that is the most common thing that generally at the bedside we come across the decision to go how much to be given. So whether hemotoxic, neurotoxic. Sometimes we know about the snake, or sometimes we don't know. In this case, we don't know even that the patient himself did not feel that bite and all. So, do you think like is it about the patient coming to your at the early presentation versus delay presentation? Does it make a difference in the number of doses that we have
No.
to look at?
You see, if this patient with early is there, you try to actually block the free venom with antivenom. So most of them, like this patient, is the severest form of it, requiring 25 to 30 units. In blood, in coagulation or endotoxin time, it is relatively easy. You can titrate it better with the clotting time, etc., and the local swelling which is happening. In these cases, first march will stop, and then the recovery starts. That's an endpoint. So usually we tend to give 20 to 30 units when it's a clear one. I think he should have been received 30. That's why it took a little longer time. Otherwise, 42 to 72 hours. It's such a severe envenomation. Which go usually 20 to 30 units. We tend to use it, and quite often, sometimes we have used even up to 60 units. But it all depends upon it. Most of the well-fed snakes which we see, 0.6 mg will be neutralized. That becomes 6 milligrams of 10 ml vial. So when you use 30, it will each will have 10 ml. So each ml will contain 6 milligrams. So roughly this is how we go with it to neutralize it, right?
Yes.
So that's part we need to see. Otherwise, there is no need to go extra because then you can have a significant issues. Secondly, you need that adrenaline is given now before injecting antivenom so that anaphylaxis can be prevented. Because if anaphylaxis happens, then there is a challenge. So there you again have to neutralize and then give it under the adrenaline drip, this anti-snake venom, because that is the only treatment. Otherwise, if you don't give it, they may take up to 4 weeks to completely recover. That is the time it takes. Is it clear?
Yes, sir. Yes, sir. Saraswati ma'am, I think most of the times at the bedside, another thing when we are giving atropine and neostigmine challenge. So generally the people say, what is the approach and how we generally have to give and what are the things you were asking that question to our students also. So what do you think is the approach, ma'am? Like your practical insights.
I think atropine first because neostigmine again will come up with its adverse effects of bradycardia and things like that. So basically to overcome that, so atropine first, and again be ready with your resuscitation equipment because sometimes these patients are anyway so unstable. So very close hemodynamic and obviously respiratory status monitoring becomes very, very important in these kind of patients. So you need to keep your crash trolley ready and keep a very close watch on the hemodynamics and the respiratory status. So that is extremely important. Yeah.
So the most important thing that we have to look at is the improvement in ptosis, probably in the initial
Yes.
period, as sir was telling, like sometimes it may be craniocaudal versus the improvement may be from caudal to cranial. But anyway, initially the ptosis is which is the one which is most obvious. The improvement, that's what very obvious we can look at. So that is one thing. So regarding the complications, Dhruv Chaudhary sir, I think you might have looked at so many cases in your experience. What are the different complications that you have come across in these patients, and what was your experience upon that, sir?
So we have we have ventilated more than 800 cases because each session 50 to 60 cases do come up. First is obviously delayed in diagnosis. So in these cases, if you suspect snakebite, keep on doing it. One of the golden rule is acute myasthenic syndrome, early morning, it's snakebite, nothing else. So you look at 4Ds, diplopia, drooling, dysphagia, and dysphonia. That's how we look at it. And for the neuroparamedic. And then subsequently, besides this, obviously complications is you can have pneumonias, but far more complication we tend to see if you take care of this is dominantly happens to your patient with endovascular, endotoxic, or coagulopathic. There one has seen Sheehan syndrome, alveolar hemorrhages, gangrenes. There you can have to actually compartment syndromes where multiple kidney failures, a lot of these things. When I was at Chandigarh, we used to see quite a lot of it. And along with it, the complications of anti-snake venom. Give ASV only and only when patient has clinical symptoms of it, local or systemic. Secondly, you should not try to put the tourniquet. If you want to do it, it should be put your hand or you put your finger inside. Lymphatics are the ones which takes it away. So that is what you have to do. And if somebody comes to you with the tourniquet, never open it without the adrenaline in your hand, or you may give a shot of ADR intramuscular and then open it up. When I've seen people die with that. And secondary infections are the other ones. So you can have complications because of Sheehan syndrome, because of pituitary apoplexy. These are dominantly seen with the vipers, especially the Russell viper or soft scale viper. There you will see a lot of bleeding, internal, external. So you may have to give cryoprecipitates, etc., to normalize. But the best hemostatic there again is ASV.
Yes, sir. That is the very important point, I think. So I think this early morning myasthenic syndrome, as you were stating, sir, most of the times the people who don't know, like if they did not come across this type of presentation, sometimes they will not be suspecting the snake bite itself. I had seen in my experience, especially and the ICU where I worked previously around 7 8 years back. So we had that such kind of patient actually. So the suspicion was not there at all. Most of the people thinking is brain dead and all. So I think after one
I
or two
think that
days,
is very important. In fact, we published around 10 years ago our experience of 192 snake envenomation in Indian Journal of Toxicology, basically forensic toxicology and all. And we had 6 cases. That means roughly 3% of the total cases had this locked-in syndrome. So that I think that is very important, and this is very rewarding. They go walking out of the ICU. But remember one thing: these are the people, they are conscious, awake, except for the initial cloudiness probably. So please do use Dizilam for muscle relaxation. Forget about that. More than that, amnesia and mild sedation. That is very important.
yes, sir,
Right,
yes.
dear?
Yes, sir. Yes, sir. I
Thank
think
you.
last question, sir. I think you are here. We want to have some more time
Because
of you.
somebody is sitting at home, मेरे को करना था, आप बताओ.
The tips to the students, sir. I think you are telling about physical examination important and all. Probably Saswati madam and Dhruv sir, both of you, give the tips like one or two sentences from your point of view when they are giving exam, especially like DRNB and DM. So what do you
See,
think?
learn diagnostic skills. DM is not simply investigations. Long term is the person. Skill set is one part, clinical doing other things. But very important is clinical physical examination and interpretation of basic tests. Everybody talks about ACMOS, etc. Fair enough, you need it, but your edifice should be on very strong. Your edifice should be strong. I think that is something which intensivists have to realize it. It is not simply putting tubes.
Correct, sir. That
They
is
must
paramount
have
important.
diagnostic skills if they want to stand independently on their feet.
Saraswati ma'am?
Yes, absolutely. And I think nowadays what happens, especially when a neurological patient comes, how many of us actually look at even deep tendon reflexes? It is so important. How many of us look at the pupils? Pupils probably, yes, we look at because it's a part of the whole process. But it's extremely important, even cranial nerve examination, that'll usually, please make sure that before you go for your exams, or rather every time, in patients who are able to cooperate, start with them. Or if you don't want to deal with the patients, do it on each other. That will give you the best way how you assess the cranial nerves, right? So try it on yourselves, try it on each other before you go ahead and do it, because it is extremely important, you might be thinking it's completely crazy. How can we test each other's cranial nerves? But in an examination, if you go and you try to assess it for the first time, it's not going to happen. Because even very important, this muscle power. How many of us look for muscle power, isn't it? So it's very important when you go and you get a long case, a neurological examination, you must be able to assess what is the muscle power. Yeah. And it will not come easy to you if you don't have a practice, right? So please do it. That
That's
would be
very, very important, ma'am, because most of the times in intensive care, our critical care colleagues generally don't stress much upon neurological examination. As you said, it is very, very important. Most of the times, it gives very good clues towards what is the
yes.
possible diagnosis and all.
Absolutely.
Very well taken points, ma'am. I think, yeah, with that, we come to the end of our session. I think we are very privileged, and it was a very good, nice discussion. I think more than 130 people logged in to listen to this session. I wholeheartedly thank Dr. Dhruv Chaudhary sir and Dr. Saraswati ma'am for giving your valuable time and teaching our students, ma'am. Thank you very much, and thank you very much, sir, madam, and sir. And I thank our students, Dr. Vikas and Dr. Avikant, for bringing out their very interesting case, because of which we had a very good discussion. And I thank our Yashoda Hospitals and our digital and branding team for regularly providing this platform to have such a very good webinars. And thank you, everyone, and good night. Yeah.
Thank you.
Thank
Thank
you.
you.
Thank you,
Thank
ma'am.
you, Dr. Kaladar. Well done, Dr. Vikas and Dr. Ravikant. Yeah.
Yes.
So these were just prompts to go back and look at what you can. Yeah. Thank you
Correct.
so much. Thanks. Bye.
Thank you, ma'am. Thank you. Good
Bye.
night.